Good evening and welcome to this webinar where we are going to discuss how we can simplify post-surgical wound care using Flaminol. My name is Luxmi Dhoonmoon. I'm a nurse consultant tissue viability at London Northwest University Healthcare. I have experience both in acute and community care, and hence today I will be sharing my personal and professional experience for both settings and how we can use these experience and lived patient experience to facilitate the transition from hospital to community care. So we're also going to be supporting self-care, shared care, and how we work in partnership with patients to deliver smooth transition. I hope you enjoyed this session. So the objectives of tonight will be the understanding of the composition and the function of Flaminol, why ease of use matters in wound care, because we need to keep things simple if we want patients to be the partners in wound care. We need to also explore its roles across care settings, the care homes, nursing homes, residential home, mental health settings, community settings, or even inpatient acute settings. I will be sharing with you some real-life case studies, and we will also review some supporting clinical evidence. So I just want to highlight how, during this session, my aim is to support my colleagues, nurses, with practical knowledge, but also emphasize the relevance of the product, how we can support us nurses and clinicians across any settings to work with patients. So let me take you through some facts. As you know, Guest al. in 2020 did loads of data and was an eye-opener for us clinicians on the wound care burden in both community and NHS. The annual level resource use is attributable to wound management, and that's 54.4 million directly to district nursing and community nurse visit. And as you can see, to healthcare assistant and eventually to practice nurse visit, 28.1 million. But most alarming is the annual NHS cost of wound management was 8.3 billion, of which 2.7 billion and 5.6 billion were associated with managing healed and unhealed wound respectively. Most wound care takes place within the community settings, as we know, and with the decline in the number of community nurses over the last 10 years, and this data is from the Queen's Nursing Institute, the challenge to provide ongoing wound care for patients with complex wounds or even simple wounds will become worse with the demands outstripping the current resource. So this is a mismatch between the demand and the available resources, which has placed considerable pressure on the NHS. And further facts, as you can see, the annual prevalence of wounds keep increasing between 71% to 2012 and 2013 and 2017-18. And we need to have a structural change within the NHS in order to manage the increasing demand for wound care and improve our patient outcome. Hence, our proposal tonight is, how do we promote and implement supported self-management model so we can work together and reduce that pressure on the NHS, on our colleagues, and on the care that we deliver. This approach encourages patients to take greater ownership of their wound care, fostering proactive rather than reactive measure. We also, as you know, have got the NHS 10-year plan to think about and how we implement, adopt, and adapt its findings in our daily wound care management. So what types of wounds do we see on a daily basis? Just some of them. Moisture lesion, including your incontinence, either associated dermatitis or any type of moisture-associated dermatitis, pressure ulcers, leg ulcers, perianal abscesses, pilonidal sinus, surgical wounds, episiotomy wounds, adult and children wounds, trauma wounds, burns, including your radiotherapy burns, skin tears, fungating wounds. Think about your C-section wounds. Think about these abscesses where patients come for a day surgery, have it incision and drain. So can we self-care? Can we encourage patients to self-care for any of these wounds? Think about yourself today. Have a moment to reflect. how many of these ones do you think you will confidently encourage your patient to self-manage or supporting self-manage? And personally, from a tissue viability point of view, we have learned a lot about self-management recently. So we can self-manage or encourage self-care or self-supported care pretty much for all of it. But obviously, it comes with some challenges and barriers. If we are ready to face them, there's nothing stopping the patient taking care of their wounds. So why self-supported care? Self-supported management is anticipated to yield that numerous benefits, including your adherence to treatment plans, enhancing that patient awareness of their condition, making better overall well-being, because once the patient is looking after themselves and their physical health and their wound, they know how to plan this around their day-to-day living. It reduces time and cost associated with frequent healthcare appointment, which sometimes it's not needed. So the COVID pandemic, what have we learned from it? It actually taught us a lot of benefit towards self-management or supported self-management. What it is, it's further accelerated the move towards self-management as a public health measures such as social distancing, isolation, reduced face-to-face appointment, where we were required to support patients, their carers, their loved ones, to take a more proactive role in managing their health. This was particularly evident in wound care, where reduced access to healthcare professionals, including tissue viability nurses, general practitioners, general practice nurses, community nurses, shifted more responsibility to individual. However, successful implementation of supported self-management relies on the patient possessing the necessary knowledge, skills, confidence to manage their health and long term. There is a recognized need for consistency in the language we use to describe these approaches, such as supported self-management, self-care, and shared care. You will hear me tonight using these three terms interchangeably, yet they may apply different levels of patient involvement depending on the context and our own clinician approach. So the principles of supported self-care is where we put the person, the individual, at the center of their care. It recognizes what really matters to that patient, considering their life as a whole, including relationship, personal interests, and their everyday challenges. It includes the people who are treated as equal partners in the discussion and decision taken about their health and well-being, and with their experiences and knowledge, because it's their own lives respected. So they know what they can do and what they can't do. We are encouraging them to set their own goals, use patient diaries, because we give it to them for them to create what's realistic and achievable for them. We're breaking these goals into smaller yet manageable steps. We are supporting them by a tailored plans for the individual with their personal aims, rather than based on what others should think we can achieve. We actually want the approach focuses on building that skills, that confidence, with the motivation to take control of their health. Because when they see what you're giving them, the tool, the knowledge, the confidence, the skill to use it, it actually brings that motivation that, yes, I can do it because I know I have somebody to reach for if I need anything. And usually people are offered the tool and guidance to improve physical health. When you're giving them that confidence to take care of their wound, it also helps them. Yes, I need to eat better. I need to eat more protein because my wound is moderate exudate, which means I'm losing the nutrient. That helps them plan. What should I be eating better? How should I be eating better? How should I be managing my pain? Because it's all to do with that holistic approach that we're encouraging them to do. But remember, open and two-way communication between patients and clinicians is very, very important if we are to encourage shared decision-making. It's the core element of supported self-management. To support greater patient involvement in self-management, it is very essential that we select a dressing regimen that is both simple and safe for the patient and the caregivers to apply. Do not complicate them with layers and layers of sandwich dressing. then you're going to lose them on that journey. Just try and make things as simple as possible. So we do have some challenges in post-surgical wound care. And if you think about the type of surgical wound care I mentioned in my previous slide, we need to know how effective our management need to prevent these complications happening. We can get infection, we can get dehiscence, and we can get delayed healing. We can get also early discharges. For example, our C-section patient or patient with pilonidal sinuses, perianal abscesses, or even a simple IND, incision and drainage of the abscess. They do not stay more than 24 hours. So there are discharge pressures. So we need to be sure we are ready to adapt and adopt that system with our patients so we can prevent the complexities from happening later where infection, dehiscence, and delayed healing can happen. And all these complexities are managed in the community. So this is where we know the community already got challenges. So why do we add to them? But if we get the patient on board early enough, we can reduce these complexities in the community for wound management. By doing that, we are also increasing the reliance of shared care and reducing the pressure on nurses and other healthcare givers. So documents have been published a lot about self-management, holistic wound management, in wound infection prevention and management, for example. The left top corner of that document very clearly says we need to empower the person, we need to empower the family, the caregiver to engage in wound care decision. And these have been here years ago, but yet we are reluctant to do it. We need to involve the person and the caregiver in establishing the care goals and care planning. We can't do that for them because we need to work with them for them to do it because they know what's achievable, what's realistic, what they can or can't do. And we need to build that therapeutic relationship where we provide a person-centered education. That means different patients will receive different level depending how much they can understand and they can retain. What works for them? What language works for them? Is it just pictorial or do you need to keep it a simple language just to make sure that they understand it at the same time? And we also need to be sensitive to their cultural and spiritual needs. So this for me is really important because many documents focus on about empowering the person and their family caregiver, but yet we are seeing a lot of reluctancy to let the patient take control of their wounds. We need to remember early recognition and addressing factors that could contribute to a person developing a wound infection and implementation of an appropriate care plan extend beyond wound level intervention. It's fundamental if we want to reduce that infection and prevent it from happening. It's also effective management when we are considering the person's psychosocial, financial, comorbidities, and capacity to heal, requiring an interdisciplinary approach. That means it's just not the nurse and the patient. It's everything that comes around it. How do they feel? Well-being wise, do they need any further support? Are they eating it adequately? Do they need any supplement? Would they need any prescription for social prescription? Or will they need any pain management or appropriate pain relief required for them? Will they need mobility support? Will they need a referral to therapists? Do they have the right footwear that will enable them to reduce pressure to that area if it's on the lower limb, on the foot? Do we know if that patient is sleeping well or have got any other comorbidities that are impacting on their sleep? So all these things require that interdisciplinary. Wound care is not just for community nursing, district nursing, tissue viability, or nurses. It's everybody playing their part towards that wound healing journey. So let me now introduce you to Flaminol. What is it? And why do we want it to be used as a simple yet effective regimen in self-supported care? So Flaminol is an enzyme alginogel. As you can see, it's got glucose oxidase and lactoperidase. What are they and what do they do? So it supports that moist wound healing while managing your exudate and reducing your infection from the wound bed. So for me, it highlights the simplicity of a one-step application. You have it in two different, hydro or forte. It's the alginate contents that's different in both of them. They're both antimicrobial and they're both safe to be used in self-supported or self-care management. It provides you the moisture balance that you need. It provides you the debridement action that you want to achieve. And it also provides you the ongoing antimicrobial action without causing any resistance to the patient. What is it? As I said, the debriding action, it gets rid of what we don't need from the wound bed. It has the alginate, so it gives you the absorbency properties, the absorb. And we have that continuous antimicrobial enzyme system. Let me now talk you through the wound bed preparation and why it's facts that we can use it for all type of wounds. As clinicians, we use the TIMES acronym. The TIMES acronym, which is type of tissues, I for infection or inflammation, M for moisture, E for the edge of the wound, and S for the surrounding skin. We use it because then it supports our care plan. It supports the wound management that we're going to devise for that type of wounds and why we think this particular regime or dressing or what we are going to use is suitable for this one. So Flaminol can be used in all 5 aspects of the TIMES paradigm because, as I mentioned before, type of tissue, if we have slough, we know it's going to debride it. So it promotes that continuous autolytic debridement. It also gives us antimicrobial protection, which means for the infection, we know it's going to get rid of any infection sitting in the wound bed. And for moisture, it maintains that moist wound healing. And with Flaminol, as we know, it's absorb exudate, but at the same time, it gives you the environment that we know the wound needs to heal. So it create that moist wound healing base for your wound bed to thrive. For the edge of the wound, it's safe for the skin and it's safe for the tissue because it protects the wound edges. It doesn't cause any excoriation or maceration because Flaminol doesn't donate moisture. And as for the surrounding skin, as I say, it doesn't damage your surrounding skin at all. So this is why Flaminol can be used in all 5 aspects of the TIMES paradigm. And as a healthcare professional, we find that instead of having multiple dressing to do the different aspect of the TIMES, but just by using one, we can achieve all 5. And I highly recommend Flaminol for the wound bed preparation in that case. So why Flaminol? Because it gives us the ease of use. And remember, this session is about patient as our partners. For clinicians, it's fine if you want to use complex dressing, but we want the dressing selection, the regime, to be simple for our patient. We want the product to be ease of use because we want protocols to be simplified. We want adherence to be enhanced. We want to reduce the frequency of dressing changes, and we want the patient and the carers to be able to use it. So how does it support all 4 of them? It's very useful in a situation where highly skilled intervention is limited. It's designed because it's accommodating wounds with various shapes and sizes or even areas like the perianal area or the episiotomy wound, where these patients are reluctant to go to their practice nurses daily because some people, they don't feel comfortable about it. And it's a choice for self-supported management because it's allowed the patient to confidently participate in the wound management while maintaining that dignity. So it's really why it supports the transition in care. If I'm starting it from the hospital, the patient can continue to use it on the journey home. That means there is consistency on using the same dressing. They know they have been using the hospital. We taught them how to use it. It simplifies the discharge planning, where if the patient doesn't want to go for practice nurse or doesn't meet the criteria for district nursing, we can teach this patient how to use it. So it really facilitates that continuity of care because it reduces that complexity, as we say, in the transition of care. A patient can be discharged to any care settings and the care remains the same. So there's no variation. There's no, I don't have this dressing, or it's too difficult for me to use it. So it's compatible with a variety of secondary dressing as well. So I'm going to talk to you through some case study of self-care where we've had used it very successfully. And I will also share with you some findings where I have implemented an audit with patients and clinicians who've used it before and after, and that's their real feedback. So this is a gentleman that was admitted with an insect bite and which caused a deep abscess in his foot. This gentleman works as a tube driver and he's required to wear appropriate footwear for his work. Unfortunately, he didn't want to take time off, and his wound, when we saw him, had a depth of 1.5 centimeter, was sloughy and had moderate exudate. Our aim for this wound, as you will see straight away when you look at it, if you think of the TIMES, you know we've got slough, and our aim is to get rid of that slough, debride that slough. That's your T. As part of your M, he's got moderate exudate. So we need to manage this exudate effectively and at the same time promote that moist wound environment. We introduced Flaminol Hydro for him and asked the gentleman, taught him how to use it. Basically, wash his hand properly after he's had a shower, put the Flaminol Hydro directly on the wound and just protect it with a foam dressing. He's done that twice a week, and within 3 weeks, he was completely healed. He came back, we checked him, and we didn't need to see him again. So this is why, we encourage this patient to stay at work. We're encouraging them to take control of their wound, and at the same time, there is a satisfaction that they've seen the promotion, the granulation happening, the improvement from their foot. And he didn't need any further follow-up. He didn't need to attend his GP or practice nurse for follow-up. He was happy self-caring. My second one is a shared care scenario where we had a 70-year-old male post-orthopedic surgery, which we had a wound depth of 6 centimeters. This gentleman was actually shared with the community nurse, and his wife was very keen to be part of his wound healing journey. Although he was 70, he was very, very keen to have hands-on. He wanted to be partners in wound care. The Flaminol we used, because obviously the wound, how it looks, it was 6 centimeters deep, was still a bit sloughy. We decided to go Flaminol Forte, and because of the depth, we showed the wife how to use a syringe to put the Flaminol in the cavity and just protect the top with a secondary dressing. So it was just a 2-step. He was able to shower with the dressing, and after the shower, the wife just cleaned the wound, used a syringe, inserted the Flaminol Forte in there, protected with a Mepilex board foam dressing, and that's all he did every 48 hours. The district nurses visited the patient once a week, as the wife was very confident to do that in between. By doing that, we've been able to not just increase the patient confidence, but also the wife confidence that she was able to do something very rewarding, because the wound depth was reduced considerably from 6 centimeters to 1 centimeter when we saw him. And this is just, and this is just him after 4 weeks that the district nurse saw him. That depth that you saw on the first one was going 6 centimeters. After all the stitches was removed, that was what was left with, and he had a 1 centimeter depth only. So it's that rewarding that you see for patients, and you can actually see it was very, very well received by both the patient and the wife. The third one I've got is just to show you how quickly Flaminol works. The first photograph is where we use it on a wound that was 100% slough, but we still had some stitches in the abdominal wound, and it was so thick slough, but because there was bowel underneath, we couldn't debride it manually, physically, using curette or sharp. So what we did, we apply some Flaminol Hydro using a syringe in the wound bed, protected it with a foam adhesive. 3 days later, 70% of the slough was gone. And this one has now healed as I'm speaking to you, because it has, continued, and we continue with the Flaminol, and it's progressed right up to the surface now. So what are the benefits, and why do we want to encourage patient. This patient, as you can see, was self-caring already with his stoma. So he did ask, why should nurses do my wound? Can I not be taught to do it at the same time? Because then when I go home, I want to continue doing it. It gets me back to my life, and this is the outcome of it. So it's really important that you discuss it with your patient, you speak to them and speak to them about why it's important to be part of that journey. What were the benefits of what I've just shown you? We've introduced self-care to a wider range of people, their relatives, the informal carers, the patients themselves, or their friends who were keen to support them, and the patient was keen to be supported by them. The patient understood their responsibility with that wound care management, and it was an agreement that they have with their healthcare professional to have regular virtual reviews or even regular weekly reviews that you saw the second case scenario where district nurses were attending once a week just to be there as a support mechanism to both the person and their relatives. The key ingredient here was patient who wish to retain their independence and autonomy, you have to allow them to do so. And they were able to do so by, encouraging them to self-care. They take a very, pride of being able to share it with the healthcare professional. They really are share the enthusiasm because they were able to redress their wound and nurture the improvement, which means they have a big hand in there. And it's really a moment of pride. So the patient feedback from the cases that I've used for ease of self-care with using Flaminol, what I've been told, it was simple, it was clean, it was not messy, it was not leaking everywhere. Where you put it, it stays there nicely. It reduced pain straight away because it was soothing, it was non-adherent. They were reassured in healing because patients said they feel safe and protected because they could use the same thing from day one of their wound till final stage of healing. It supported their independence. They were able to self-manage at home. My patient with episiotomy wound have been able to do that until they were completely healed. Similarly, with our pilonidal patients, they have to do it themselves. They had their daily hygiene shower, and then we taught them how to put the Flaminol directly on a pad, on a non-sterile pad. So, for ladies with episiotomy, they were using the sanitary pad. They put the Flaminol directly on that and just secure it with their underwear. As simple as that. So, and also it improved the comfort in mobility. There was no pulling, tightness under the dressing. It preserved their dignity and privacy. Not everybody wants nurses. And as we know, in the community, you don't only get one nurse to see them. It will be different people. And not everybody is very comfortable with that. And the reliance on others, so that will also reduce it. So these are the survey that I collected, and this is what my patients have said. And this was a survey about 10 patients that I collected pre-using Flaminol and post-using Flaminol. I felt confident doing it myself once the nurse showed me. It didn't sting when it touched my wound, which made me less nervous about changes. The dressing came off easily without pulling on my skin. With my new hip, the gel kept things comfortable under the dressing. I could manage my wound myself with privacy, which was more important to me. And from my nurses, my clinicians, healthcare assistants, practice nurses, and nurses who've used it, they reported patient confidence was reduced, it was improved, they reduces their anxiety, and it builds a self-belief. It was very easy and straightforward to teach them how to do it. It was comfort and safety straight away at application. They reported non-stinging and non-traumatic dressing change. They were really happy that patients take ownership of their wound recovery. It supported safe discharges because that was a continuity that could be done by the patient themselves at home. It preserves their dignity and it enables private self-management. And this is what they've mentioned. Flaminol is simple to teach and patients quickly gain confidence in applying it themselves. Because it doesn't sting or stick, patients are more willing to continue with self-care. Encouraging self-care with Flaminol helps patients feel more independent in their recovery. It's an ideal product for supporting safe transition from hospital to home care. Patients appreciate the dignity of being able to manage their wound privately. And these, as I say, are real clinicians' feedback that was collected. So here are some evidences. Flaminol has promoted autolytic debridement and continued antimicrobial. It's CE mark and is supported by multiple clinical studies. So, there are many, many studies that should reduce infection rates, improve healing time, and good patient tolerability. And this is available on the Wounds UK website, where there is loads of free downloadable papers, and it's also in the International Wound Journal. So please do have a look, because it's really important for you to know what product you're using and what evidence back you when you're talking with your patient. So some practical application from my point of view, from what I encourage patients to do, is cleanse the wound. And that, if you're a healthcare professional, obviously you're using your non-aseptic touch technique. But if you're a patient, encourage them to have their shower or wash their hands before their wound care. Apply a 5mm Flaminol layer. If, as I said, depending on what your wound, if it's an abscess, in using a syringe in the cavity, or if it's a pyrenoidal or episiotomy wounds or an IND wound, you just put it on the wound surface. You cover it with a non-adherent dressing if required, because very often if the pyrenoidal or perineal abscesses, we're going to be doing daily. So patients use like pads, sanitary pads, or non-sterile pads. And it's changed every 1 to 3 days, depending on what you think at the point of assessment your patient need. So I'm going to show you now a simple demonstration of a 2-way process, which I find very useful for patients when they've been using. Please ensure aseptic non-touch technique is used. As you can see, any wound, perineal abscesses, surgical wound, pressure damage, once you have a cavity, you use your sterile syringe, you fill it with your Flaminol, Hydro or Forte, whichever one you're going to use, and protect the wound with a secondary dressing. In this case, I'm using a foam adhesive to capture the exudate appropriately and protect the peri wound as well. This is to ensure that my patient is safe. It's only a 2-step process, and this is another wound where I've also provided supported self-care, where the relatives have helped the patient to have Flaminol. As you can see, we go in the undermined area first, and then we lay over the 5mm thickness of Flaminol in the wound bed and protect with your foam. As easy as that. So this is our 2-step process to help support self-care, self-supported care, or patients who even want to be part of their wound healing journey using Flaminol alongside a healthcare professional. So as following the what you've just seen, I'm just going to give you an example of the pathway that I use in my trust and how we have used these pathways to promote self-supported care. So, for example, pyrenoidal abscesses, sinuses, or perineal abscesses, many patients are able to deliver that self-care. And these patients, because they're ambulant, they not always are able to attend practice nurses because they may be working. We have as young as a 16-year-old having pyrenoidal sinuses. So teaching them how to self-care. So what we do, we print the pathway, we give it to them, we give them syringes and show them how to put it on the pyrenoidal area. And at the same time, just use a pad, protect it and support with the underwear. If they have a wound, other than the abscesses or the episiotomy wounds that they need to use a foam, equally, we follow the path that I've shown you on the video where they have the foam adhesive to go on top of it. So we have different pathways. All these are done with patients because it has to be user-friendly by the patient, a step-by-step guide to support them. So hopefully from here, you would have seen that the key messages I want to give you is it's effective, it's easy, it's a dual action care. And it reduces the frequency of dressing changes by healthcare professional. But it's not because we don't want to do it, it's because of all the challenges happening in the community and the acute. We want patients and their carers to be partners in that wound healing journey. It supports the transition from acute to community, and it promotes that empowerment that we want to our patient. And finally, it's clinically supported. So it's really important that we know it meets the needs of both the professionals and the patients across all settings. So I hope this session has been, good enough for you. You've learned something that you can take straight away to your practice. Please do not be scared to self-care or promote self-supported care with your patient. There are loads and loads of pathways to support you, but most importantly, remember, it's that communication. Make sure your patient understand what's required out of them and what you are willing to support them with. So these are some references, and for you, if you want to check and have some further reading. Other one that I do hope you have time to look at this paper where it was published in recently. It's how to implement supportive self-management in wound care. It's part of the reference list as well. I thank you very much for your time and wish you all the best in implementing self-care, self-supported care, or even empowering your patient to take control of wound care. Thank you. Thank you so much for paying attention to this to the slides. And I have got some questions and very happy to answer your questions. I will start by the question is, why is there reluctance, as you said, in letting patients look after their wounds? So from a nurse perspective myself, very often, and having both community and acute, I think challenges is we don't have time to teach the patient. It takes time to make sure the patient have it right, get it right, understand what they're required. So for me, it's one, we don't have time to teach them. Number two, it could be that the clinicians also worry that they will be held responsible if complication occurs after self-care. And number three, it's also, culturally, organization factors. Wound care has always been a nurse-led thing. And by letting self-care take over, we feel like we're losing control of our wounds. But I think COVID has taught us that, no, now is the time to move on and actually take patient with us. So that's my answer to the first question. And your second one is, why can Flaminol 40 only be started as part of treatment by tissue viability nurses? Nope, you're completely wrong. You can start it as an RGN because you're doing a holistic assessment. If you feel the wound requires Flaminol and it's on your formulary, please do start it. You do not need a specialist to tell you that it is. Yes, it's an enzyme alginogel. It sits usually under an antimicrobial, but provided you've done a good assessment, then there's nothing stopping you from starting it. And my third question is, I would love to know which wounds to apply foam dressing. And during the case studies, foam dressing were mentioned. I will use foam dressings on a wound that I do not change daily. So if a wound has got exudate and moderate to high exudate level, I will use a foam dressing so it can absorb the fluid properly and doesn't create maceration to the peri-wound. But at the same time, if things like I've mentioned in my presentation that needs daily, I would not use a foam because that's not cost effective. And I think when using Flaminol 40 in a cavity, what secondary dressing would you recommend? Or if it's a cavity, definitely there will be exudate. I will always protect with a foam adhesive. Obviously, if it's in an area that can get a foam adhesive. If it's somewhere by the natal cleft or something like that, we may use something different, like an absorbent pad secure with some film dressing, because that will may need to be changed more often. Sorry, I'm looking at the question. Is Flaminol new on the market? Definitely not. I've been using it for God knows how long now. It's definitely not new on the market. Please do reach out to your local representative to use it, and or through, via the presenters, the host. It's really important you get to know what products are available to you to make things easier for wound care. And Flaminol's been there a very long time, and there's loads and loads of live patient experiences and clinician experience published on it, and that will help you guide your way through. When do you use hydro and when do you use forte? So I use both. And the difference in both flaminol hydro and flaminol forte is only the content, the alginate content. So flaminol forte, as the word say forte, has got slightly more alginate content than flaminol hydro. So like the one that I showed you, I needed to debride. I wanted it to autolytic debridement quicker. I use the flaminol hydro just because it was debriding it more quicker. Whereas if a wound has still got slough, but it's very wet, I tend to use flaminol forte because I know then flaminol also absorbs the excess fluid. Can flaminol be used for burns? If so, which one is recommended? Hydro or forte? I use flaminol all the time for burns. And I use flaminol forte as well if there's slough, but I also use flaminol hydro. Remember, you can use either. It's not a mistake which one you use over the other one. It's just the alginate content that's different. We also have another product for the flaminol family that's directly as relevant for burns. But you can use your flaminol for burns, and even the burns you need to use flaminol a lot on managing burns wound. I think that's my last question. Can flaminol be used on a tunneling abdominal wound that is 4 centimeter deep but narrow in diameter? Definitely. Let me tell you how. So you have your sterile syringe. You pull the plunger out, squirt your flaminol at the back through the syringe, and then the tip of the syringe goes in the narrow opening and you squirt it in. And the good thing is flaminol doesn't need to be irrigated out. It absorbs in the tissue where it promotes the granulation from base up. With a narrow opening, you cannot actually pack. One, it can be traumatic for the patient. Two, it can be very painful. And you may not be able to pack any alginate in there anyway, or ribbon. So using the syringe, the flaminol will actually reach the base of the wound. So you are 100% confident the wound will be healing from base up and not just cover the end part of the wound bed. So yes, please, if you have got deep tunneling wound with a narrow opening, go for your syringe and squirt the flaminol forte in there. For perianal abscesses, what is your recommended secondary dressing for after flaminol? So for perianal abscesses, my patients tend to do daily. So we ask them to shower, not to use any soap or bubble bath, just plain water, warm water, dry gently with paper towel. And then we put the flaminol directly on a pad. And that could be just a non-sterile absorbent pad or the sterile pad, like the small absorbent pad, 10 by 20 centimeter. We put it directly on the wound and just secure it with their knickers, their underwear, or net knickers if they are in bed. So that's how we will use for perianal abscesses. The fact that it's done daily, it's more cost effective to do it that way. You do not want to stick any secondary dressing because it might be traumatic on removal as well as not cost effective. If you do have any questions, please do put your question in. This is your time and opportunity to learn more about flaminol. As I say, if you haven't used it, please do give it a go. Read through the research, get through your company rep, get a sample, and just use it for yourself. You will see how difference it make on your patient. It looks like we don't have any more questions. What are the most common barriers to self-care you see? The most common barriers to self-care is if the patient themselves refuse to do it. They just want a professional and a clinicians to do it for you. And the second barriers I see is sometimes language barrier. If you don't have the right translation, patient don't understand, so they're reluctant to do it. That's from a patient point of view, but from a clinician point of view, the barriers that I see is clinicians sometimes, they don't see patients having the ability to do it. They're worried that patient will not do it the right way. They're worried about patient don't have the ability to self-care. So these are some barriers that easily fix, but it all comes with education, be it for myself as a clinician or for the patient. Both of us need to put a patient in, like, educate ourselves first so we can overcome these barriers, and educate our patients so they understand what we want from them. So that's really how we're looking at it. Any more questions? On the natal cleft for a moisture split, would you use Flaminol and a dressing or just Flaminol? Well, if you have a read at the paper that I've published and many others that I've done for Journal of Community Nursing as well, you will see that I use Flaminol Forte a lot on my severe moisture lesion where they are bordering to deteriorate further to pressure damage. And this area you can't actually dress on the natal cleft. You can't put a secondary dressing. Put your Flaminol Forte on its own. As I said, it will be absorbed in the skin, so it's not going to get washed away or anything. And just the patient pads, incontinence pad, nothing else. We do have a regime. Sometimes we say nurses to put thinly twice a day until it's completely resolved. And then we step down to barrier cream for prevention. So you can use it on the natal cleft, but without a secondary dressing. It works better. Can we use Flaminol Hydro on non-healing wet leg ulcers? You can use Flaminol on leg ulcers. Again, we have published case studies and papers on using Flaminol on lower limb ulcers and foot ulcers, even diabetic foot ulcers. And you want to use Hydro, there's no reason why. If you think it's very sloughy, it needs to be debrided. You can also use the Flaminol Forte if you think it's very wet. It will help you with that, preventing of that maceration of the peri wound. But you can use Flaminol, and we have published case studies and papers on it. When redressing wounds that have been dressed with Flaminol, do you need debride wound prior to redressing with Flaminol? No. Thank you for the questions. And as I say, Flaminol doesn't need to be irrigated out. So when it's a cavity wound, you won't see anything. So you don't need to flush it out to be able to put the dressing on. So you just, if it's on a flat surface, you have debris like debrided slough, yes, you clean it and then you reapply it. And how can we encourage better self-care for patients who are more resistant? Conversation. Just conversation and nothing else but conversation. Communication is a great key for us to have our patient, engage with us. And as I said, many patients have changed their way of seeing things since COVID. They're more keen, even relatives are more keen to be part of that wound care journey. So start the communication going today, and you will see how they come along with you. So I think that's the end of our presentation now. I thank you all for attending. Please do scan the QR code to take part in the survey. And, there is the Facebook to have the latest up-to-date on Flaminols and any upcoming events. Reach out to your local reps, and all the best. It's really important that we know what's available to us and to, make sure we're using evidence-based practice in our daily routine for wound care. I thank you all for your time and have a lovely, lovely evening.